Hello, everyone. Welcome to EONS14 conference. We will start today on channel 1 with this session supported by Baxter, cancer-related cachexia from perceptions to management. We know that malnutrition affects more than 50% of cancer patients and is present in more than 80% of patients with advanced disease or metastasis. Malnutrition often involves cancer cachexia, and it is extremely important to establish early nutritional interventions to prevent or minimize situations that can affect the nutritional status of our patients. A well-nourished cancer patient has better tolerance to treatments, a better quality of life, fewer side effects of the cancer therapies, and therefore enhanced adherence to treatments. We will start today with Dr. De La Torre Montero. He comes from Spain. He holds a bachelor in nursing from the University of Salamanca, as well as a master's degree in nursing care research and a PhD in ultrasound in vascular access. Since 2014, Dr. De La Torre Montero teaches oncologic nursing care and palliative care, along with ethic and research methodologies at Camillas Pontifical University. He has more than 20 years of clinical experience and has worked as a researcher, study coordinator, and study nurse. He's a member of EONS and also a member of the Spanish Society of Oncology Nursing. He will talk us about a large cohort study in Spain, nutritional status in locally advanced or metastatic solid cancer patients. We can start now.
Hello everyone, I am Julio de la Torre from Madrid, Spain. I'm going to present you the nutritional status study of cancer patients in Spain, performed by the nutritional group of the Spanish Society of Oncology Nursing. Last year, in the midst of the pandemic moment, we performed an interesting study about the nutritional status of our patients. We think it's important to put of relevance of this situation with our patients because quality of life is about nursing. Here is my conflict of interest moment in the past 2 years, and we are going to follow the background of the nutritional status in oncologist patient diagnosis. The situation is not very clear in every diagnosis. It depends of the type and stage of the cancer, and the situation is worse with the treatments. We know that treatments provoke anorexia, diarrhea, vomiting, nausea, and sometimes patients have a loss of weight. The incidence of malnutrition in cancer patients, sometimes affects over 80% of cancer, all cancer patients. So, for us, it's important to improve the quality of life. The early interventions impacts in the clinical evolutions, and sometimes there are lack of screen routine procedures during diagnosis, and we need to afford these situations. Patients at nutritional risks sometimes are undetected. We need to get this possibility in our consultations, in nursing consultations. In Spain, we think this issue is important, and with these studies and the assessment of the nutritional assessment in cancer patients is important. And so there are a few data. In Spain there are no data at the moment. We think our study is the first one in immunological patient with treatments, and we need to screen this situation with targeted therapy and immunotherapy, and as well as they represent the future in the field of oncology, we need to perform this study. NAS study is in clinical trials registrations, and this is a descriptive, non-interventional, observational, cross-sectional, multi-center in 10 hospitals all over Spain. And with one single visit, we perform a screening, a nutritional screening of cancer patients, and we perform a further analysis. The study objectives, we focus to determine the prevalence of malnutrition or risks of malnutrition in the Spanish population of all patients, not in patients, not all specialist patients, with immunotherapy or chemotherapy or radiotherapy. To this end, the nutritional status, we explore using validated tools as Nutri-Score and PGSGA. The study endpoints, we focus to describe the percentage of patients undergoing immunotherapy treatment with or without concomitant chemotherapy or radiotherapy who receive nutritional advice or nutritional support. We focus also to describe the percentage of oncology patients being treatment with immunotherapy or chemotherapy or radiotherapy concomitant with malnutrition according socio-demographic characteristics, eating habits and sociocultural implications, and clinical tumor stage. And finally, we perform and analyze and compare symptoms that impact with nutrition in relation to treatments. The populations we treat metastatic and solid cancer patients, solid tumors stage 3 and 4, who were in the first line of treatment. We consider that this kind of patients could be the target or study of because we estimate the first moment of the diagnosis or the adjuvant or neoadjuvant patients, because metastatic cancer patients are the shows or the real situation of the standard cancer patient in Spain. Finally, a total of 585 patients, we divide this in two groups. One control group of 200 patients with chemotherapy, with traditional therapy, and another group with 408 patients with immunotherapy alone or in combination. But this is the key question. This is the key question with immunotherapy. Immunotherapy is not studied a lot in many studies before this. The tools we perform, there are validated tools, Nutri-Score and PGSGA screening tools. They are specific designed to classify to oncology patients with the percent, and we estimate the risk, the nutritional risk, with a scoring system and classifying patients in and a risk of with or without nutritional from cutoff points of 5 points, and we have two categories. Below 5 points, out of risk, and above or equal of 5, the patient is in risk. And PGHSGA is a subjective patient evaluation with a self-performance assessment. This is an interesting tool because it's validated too, and we can predict about patient situations the risk of complication. So inadequate nutritional status, and we detect the nutritional intervention, and we need to check these interventions. So this scale, the following classification of patients has been used: the state A, well-nourished, state B, moderate or suspicion malnourished, and state C, severely malnourished. And so we are going to present the results of this study. This is interesting because we have very interesting results about, according to Nutri-Score, we have a p-value, a significant p-value in group A. In group A, there are about 30% of the patients were with risk of malnutrition, and compared with group B with chemotherapy, there was about 60% of patients. They are very statistically significant, and this is important because in monotherapy they are better for nutritional status of our patients. And about Nutri-Score and type of treatment, they are equal significantly, statistically significantly. About the mean score of was higher than in patients with chemotherapy alone. About 60% of patients with risk of malnutrition follow, but patients with immunotherapy, with targeted therapy, with only 35% at risk of malnutrition, and only with immunotherapy there are 22% of these patients. This is interesting because we have also chemotherapy alone, targeted therapy, and immunotherapy alone. The total score of PGSGA results regarding to the total score and nutritional status, there are also statistically significant difference between both groups. In group A, 80% of patients were in state A, well nourished, and about 50% in state B, moderate suspicious malnourished. In the B group, there are 67% and 32% in states B, A, and B respectively, and only one patient show a state in states C. This study shows that we don't have many patients with severe problems, but we need to keep in mind that this is important to not give up in the treatment of our patients. The nutritional support results we perform to study with nutritional support status. This is interesting because the nutritional support status show us that in Spain patients are well cared, and we have a dietary advice sometimes by the nursing professionals, sometimes by medical doctors or nutritional professionals. But we have one result in parenteral nutrition, and this shows that the situation of our patients are not too bad, but not too good. And we need to insight that the dietary advice is important to our patients. The types of nutritional intervention is shown at the slide. Dietary advice, oral nutrition, supplements, and enteral nutrition and parenteral nutrition. Only one of our patients were under parenteral nutrition. And this is important to know that the professionals in oncology field, we need to perform the nutritional status of our patients, and we need to know how make our especially the situation in our patients. And finally, we can discuss these results between another studies in another countries. And this is important because the assess of nutritional status is important, like a routine and supportive cancer treatments. In this study, the total number of patients are around 40% of patients have risk of malnutrition, and this is important. Why this is important? Because our advice, supplementary treatments they're important to offer in our patients. And nutritional diagnosis is key for cancer patients. This is key, and we show in our study that this is very, very important. According to our results, our patients who receive combined therapies and require special attention regarding the nutritional status. So, the patients who receives chemotherapy or chemotherapy in combination with immunotherapy or radiotherapy, they are have a high level of risk, and this is important to our patients because we have many patients under chemotherapy and not by immunotherapy. This is our role in oncology nursing, and we need to detecting malnutrition, and this is essential to ensure good interventions. Many studies before ours show results similar than ours. Nutritional therapy must be timely considered and prescribed. In oral intake is inadequate, and we need provide sense, and we need to consider like ESPEN guidelines recommendations. We need to think about supplemental, complemental, nutritional, and sometimes parenteral nutrition. Cancer-related malnutrition is under diagnosis, underreported, and undertreated. This is key to start a new beginning. and we need to have an early interventions with nutritional supplementation, or because they improve the outcomes of our patients and their quality of life. This is very, very important. The outcomes of nutritional assessment and therapy improves the quality of life for our patients. This is clear, and we need to improve this. And the early nutritional support and early the nutritional is important to have in mind, and to keep in mind the safety profile of parenteral nutrition in oncology patients. In all patients, they are very safe, and sometimes we need to consider parenteral nutrition when it's needed, and there are no complications with an adequate training of professionals. We need to monitor in the follow-up, and the incidence of the complications are very, very low. And this is important too. The patient perception of comfort of feeding method. There are not many patients wants to have a nasogastric tube for feeding, and they prefer a parenteral feeding. In the clinical practice, I observed this situation many times, and evidence support this data, because nasogastric tube is not very easy to go in, and we need to address this. The conclusion of this study and the future call to action, we need to put in value the nutritional status. The cancer, nutritional in cancer are diagnosticated, underreported, and untreated. We need to insight the importance of early treatment, and early the nutritional support is good, an independent prognostic factor for overall survival, and efficacy and safety. There is very important. The patient preference, the 91% prefers IV nutrition versus nasogastric tube feeding. And finally, the future is that the specialists in charge of oncology patients should assess the nutritional status and provide nutritional therapy as part of the routine of the suppurative cancer treatments. All options are available of nutritional should be considered, from dietary counseling to total and supplemental parenteral nutrition. The role of oncology nursing is detecting our malnutrition is essential, and our interventions are improving the patient's quality of life always. So thank you for your attention. My email address is there, and happy to be here.
Hello everyone. I am very honored to be a part of this symposium, and thank you EONS for including me. I am going to present you a study on the knowledge of Greek and Cypriot cancer nurses about the anorexia and cachexia syndrome. I have no conflicts of interest to declare, and these are the points that I will cover in the presentation. Anti-cancer treatments are improving survival. However, all these treatments and their side effects can play a role in the development of malnutrition and metabolic alterations in cancer patients. Hence, nutritional deficiency can become a common medical problem that affects up to 40% of cancer patients. This disease-related malnutrition has been defined as a condition resulting from the activation of the systemic inflammatory response by cancer. This inflammatory response causes anorexia and tissue damage, which in turn can cause weight loss, decreased body composition and functional capacity, and ultimately induce the anorexia and cachexia syndrome. Anorexia-cachexia syndrome is a severe clinical consequence of almost all chronic diseases in advanced stages. It has been defined as a multifactorial syndrome defined by an ongoing loss of skeletal muscle mass with or without loss of fat mass that can be partially but not entirely reversed by conventional nutritional support. Its prevalence can vary significantly depending on the tumor type and the disease progression. Its prevalence ranges from 50 to 80% in advanced cancer. More aggressive forms of non-Hodgkin lymphoma, colon cancer, and other cancers are associated with a frequency of weight loss between 50 and 60%. The mortality rates of patients with anorexia-cachexia syndrome can range from 20 to 80%. So, the syndrome can severely affect response to treatment and overall survival. Nurses are ideally placed to have an essential role in the early detection and screening of malnutrition and anorexia and cachexia syndrome and act accordingly. But while the understanding of the syndrome and its impact is improving, this knowledge still needs to be shared more widely and applied in clinical practice in a more systematic way, since perceptions and clinical practices vary among healthcare professionals worldwide. Also, healthcare professionals often face challenges in communicating with patients and their families about malnutrition issues and cachexia, and receive limited formal education both at undergraduate and the postgraduate level, and consequently have limited understanding of the syndrome. So, a descriptive and comparative study was conducted with nurses from Cyprus and Greece to explore the knowledge of nurses regarding the anorexia-cachexia syndrome within the cancer care context in the two countries. We aim to find out what are the current management practices for the syndrome in clinical practice, and what are the differences in the knowledge of nurses regarding anorexia-cachexia syndrome in the two countries. The sample consisted of 119 nurses working in oncology departments and attended the 8th Nursing Oncology Conference in Cyprus, and 78 nurses that attended the 5th Symposium of Oncology Nurses in Greece. Both conferences took place in 2018. Recruitment and data collection continued throughout the duration of the two conferences. The participants were informed on the aim of the study and volunteered their participation in the survey with a written consent form. Then they proceeded to answering the anonymous questionnaires. The nurses were able to complete and return the questionnaire through the conference duration. Inclusion criteria for the nurses were registered nurses working with more than 3 years of experience in oncology settings, and they were willing to participate in the study. The nurses completed the Greek version of the Investigation of Anorexia and Cachexia Syndrome in Practice questionnaire. The questionnaire consisted of 8 questions about the anorexia and cachexia practices and 8 questions about nurses' demographic characteristics. The 3 domains covered by the questionnaire included the views of characteristics of cachexia, assessment and management of the symptoms commonly associated with the anorexia and cachexia syndrome. For example, items included characteristics of the syndrome like anorexia, weight loss, and fatigue, and if they are regularly assessed, the actions taken for the management of dry mouth or reduced appetite or early satiety. As part of the study, 3 additional questions were included to retrieve the perspectives of the nurses on the use of guidelines for the management of anorexia and cachexia syndrome, either their educational preparation was sufficient to manage the anorexia and cachexia syndrome, and what is the level of priority assigned to the management of anorexia and cachexia syndrome in comparison to other symptoms. The response time needed for each questionnaire was approximately 20 minutes. We proceed now with the results of the study. The study included in total 197 nurses. 119 from Cyprus and 78 from Greece, with a mean age of 31.9 years. The majority of them was women. 192 had an educational level of a degree. They had an average of 8 years working as registered nurses and an average of 6.5 years working in the present workplaces. The majority of the nurses were clinical nurses. No statistically significant differences were observed between the demographic characteristics of the participants in the two countries. Almost 96% of all the nurses declared that they did not use a tool for assessing the nutritional status of patients as part of their standard practices. Only few reports were made from the two countries. For example, only 5 nurses in Greece stated that they use laboratory and blood testing, and only 3 nurses in Cyprus stated using a nutritional tool or questionnaire made by the doctor but not validated. Regarding the routine assessment of the nutritional-related symptoms, over 90% of the nurses asked the patients about appetite, food intake, diarrhea, constipation, nausea or vomited. Early satiety and hiccough were found to be evaluated by almost 1 in 2 nurses. Nurses in Cyprus ask more frequently than nurses in Greece for early satiety, hiccough, alteration of the taste or odor sensation, problems in the oral cavity, and problems in daily activities. Here you can see the anorexia and cachexia syndrome features that were reported by nurses in Cyprus and Greece. The features that were most frequently reported included weight loss, anorexia, weakness, fatigue, pain, depression, and palliative care. Nurses in Greece reported anorexia and depression more often than nurses in Cyprus, and nurses in Cyprus reported more often weight loss, weakness, fatigue, and pallor. Pain was equally reported in both countries, and there was no statistically significant differences among the variable, since the nurses' responses were similar, except for the variable of weight loss. Here are the actions for the management of dry mouth. The most common actions reported were oral hygiene solutions, washing, brushing, the management of the fluid intake and the hydration, the use of candies and chewing gum, oral gels, antifungal medicines, intravenous fluids, and the use of lemonade, lemon, honey, and glycerin. The nurses in Greece reported that in their clinical practice, they more frequently use fluid intake and hydration, candies and chewing gum, and intravenous fluids. On the other hand, nurses in Cyprus stated that they use more often oral hygiene measures, oral gels, antifungal medicines, and lemon, honey, or glycerin. No statistically significant differences were found except for the utilization of oral hygiene measures, where nurses in Greece stated a lower use compared to nurses in Cyprus. We proceed on the actions for the management of the reduced appetite. The most common actions taken by nurses to manage this symptom included the use of small and frequent meals, tailoring patients' food choices, the use of nutritional supplements, the referral to a nutritionist, a light diet, cold meals, a meal plan, and managing fluid intake. Nurses in Cyprus reported that they more often provide to patients small and frequent meals, a light and cold meal, a meal planning, fatty meals, fluid intake within the patient nutritional plan. Whereas in Greece, they reported higher percentage of providing food according to patients' preferences and the administration of medication and food supplements. Differences were observed in the use of small and frequent meals and liquid intake, with Cypriot nurses reporting it much more frequently. The most frequent actions reported by nurses in Cyprus for the management of early satiety were oral solutions, management of the fluid intake, systemic oral hygiene, and oral moisturizing gels, while the most common actions to manage early satiety in Greece were tailoring patient food choices and food intake monitoring, counseling, and encouragement. It is obvious that the nurses' views on the management of early satiety differ significantly between the two countries. They utilize different methods within the practices or with a different percentage of use for the same practices. Nurses in Cyprus reported that in their clinical practice, they more often use oral hygiene measures, solutions, washing, brushing, or oral gels, antifungal medicines, and lemon, honey, or glycerin, while nurses in Greece reported that they more frequently use oral food intake, hydration, candies, chewing gum, and intravenous fluids. Statistical significant differences were found in the use of oral hygiene measures, where Greek nurses reported lower utilizations compared to Cypriot cancer nurses. Regarding the involvement of another healthcare professional in the care of patients with anorexia and cachexia syndrome, 157 nurses from both Greece and Cyprus responded that there is another healthcare professional who joined the care of these patients. In Cyprus, nurses reported much more frequently the involvement of another healthcare professional, mostly a nutritionist. Regarding the priority management of the anorexia and cachexia syndrome, nurses were asked, what do you think is the priority level attributed to anorexia and cachexia management in relation to other symptoms? And more than half of the nurses reported moderate priority. The level of priority appeared to be differentiated between Greece and Cyprus, where in Cyprus the level of high priority was reported by 39 nurses, compared to only 10 nurses in Greece. Then, nurses were requested to answer either the management of these patients is done according to a specific policy. 83.2% answered that the management of this patient is not guided by any specific policy. Only 16.8% responded positively. There were no statistically significant differences between the two countries, and as far as the policies utilized, in Cyprus, some nurses stated using the hospitalization of the patient, the nutritionist referral, a special diet or psychological support, and some nurses in Greece stated treating the chemotherapy side effects, checking with the Norton scale, referral to a medical and paramedical staff, referral to a nutritionist, and some protocols. Afterwards, nurses were asked about their education in relation to anorexia and cachexia syndrome. 152 nurses responded that they have not been given any necessary training to be able to effectively manage patients with anorexia and cachexia syndrome. There were no statistically significant differences between the two countries. And of those who responded negatively, we asked their perspectives on what they thought is needed to improve the management of anorexia and cachexia syndrome. Nurses in Cyprus reported that measures should include conferences, education, protocols, expert meetings, interdisciplinary approach, and interdisciplinary team collaboration, while nurses in Greece reported using education, seminars, protocols, conferences, clinical nursing experience, and better understanding of patients' preferences. In Cyprus, the provision of conferences as a means to increase the better management of anorexia and cachexia syndrome were responded more often than in Greece. There are some issues to be discussed about the results. First of all, in both countries, The lack of formal education, combined with a lack of standardized evaluation tool, contributed to the inability to cope consistently with the patient's complex needs. The lack of a universally accepted cancer cachexia-specific tool is identified in the literature. Often, it is substituted by another general malnutrition screening tool. However, education and training alone are not sufficient to bring the change in the syndrome management. We have to overcome many barriers and challenges, like organizational regulations and the non-recognition of anorexia and cachexia syndrome as a specific pathology or comorbidity. Also, in both countries, nurses in their practices tend to address some common features of the syndrome. However, these were not statistically significant. So it seems that they were familiar with the risk factors for malnutrition and the signs of the existing malnutrition, but it appeared that this knowledge is not consistently applied in practice or it is used incorrectly. This finding also highlights the need for complementing the theoretical training with clinical practice and also move beyond the standard educational practices and place emphasis in the personalized educational needs of the nurses working with these patients. Then, in both countries, there is an absence of management guidelines for the anorexia and cachexia syndrome in cancer patients. Since the study was undertaken, there are now general guidelines for the syndrome, but are not yet known or not yet disseminated among healthcare professionals. Then, the multidisciplinary approach for the syndrome is recognized by the cancer nurses because they seem to involve other healthcare professionals in the care of these patients. These complex issues demand the collaboration of many professionals, and nurses recognize that. And finally, on the topic of the priority level assigned to anorexia and cachexia syndrome management, this differs significantly in the two countries, with higher priority being reported in Cyprus. This finding could be partially explained by the fact that the Cypriot cancer nurses recruited in the study had more years of experience with cancer patients and hence management anorexia cachexia syndrome, since more years of experience can contribute to the better management of the syndrome. Although the level of training between the nurses in the two countries was comparable, the content of the training curricula might not have been. For example, the training curricula in Cyprus might attribute more attention to the nutritional challenges that cancer patients face across the cancer continuum, creating an increased level of awareness among these nurses. Limitations of the study include the relatively small study sample and the chosen sampling method. In terms of the sampling method, the study relied on the nurses' willingness to participate, which might have an impact on the generalization of the results. That is because the nurses' interested in the study were probably those who recognized the shortcomings related to the syndrome, and the novel information intrigued them to participate. Nevertheless, the recruitment strategy that was utilized provided a rather representative sample of the nurses working with cancer patients in the two countries, purposefully targeting the nurses who attended the two largest cancer nursing conferences in the two countries, provided a balanced mix of the cancer nursing workforce, allowing for conclusions to be drawn. However, the participants had to complete the questionnaire during the conference. The conference setting might not have been ideal and distracted for the responses. However, providing adequate time to the participants to provide their responses has mitigated the problem. Despite its limitations, this study is the first attempt to capture the perceptions and practices of cancer nurses in Greece and Cyprus in relation to the understanding and management of the anorexia cachexia syndrome within the cancer context. So, moving to the end, this study investigated Cypriot and Greek cancer nurses' knowledge on anorexia and cachexia syndrome within the cancer care context. The results demonstrated that the knowledge background of the nurses working in this context is not sufficient to meet the complex needs of patients with anorexia and cachexia syndrome. This becomes more complex as currently a tool to facilitate the recognition of the anorexia and cachexia syndrome does not exist, whilst there are limitations to recommend clinical practice guidelines. This study was undertaken on the basis of clinical and empirical data that anorexia and cachexia syndrome is inadequately recognized and managed, leaving patients experience symptoms which may respond to available treatments and contribute to a better management of the syndrome and improve their quality of life. There is still an unmet need for nutritional education in cancer care. In order to achieve the nurses' awareness for this matter and in general for nutritional care in cancer, we need a prolonged focus on nutritional care assessment and treatment in the clinical practices. We need sustained efforts from the management to promote nurses into taking responsibility, as well as in financial investment channeled in educational programs and policies. The management of this syndrome requires a multidisciplinary team and the collaborations of many healthcare professionals of different specialties. And in this multidisciplinary team, the role of the cancer nurse and the results of the provided nursing care need to be more investigated and clarified. Furthermore, the provision of cross-country exploration studies in relation to anorexia and cachexia syndrome knowledge among healthcare professionals can potentially provide the basis for the development of a core curriculum in this field. This can form the core basis of the training program, along with country-specific elements and conditions in this context. These aspects highlight even more the importance of cross-country comparison in this field. In this point, the presentation is over, and thank you very much for your attention.
Hello, my name is Konstantina Klekoni. Thank you for the invitation to participate at this session. It's my pleasure to participate at EONS14 at ESMO 2021. I'm a research nurse at German Oncology Center, and I'm working also as a teaching assistant at Cyprus University of Technology. Today, I'm going to present you the preliminary findings from an RCT on the management of cancer-related cachexia through a multi-professional nurse-led approach. Here is my research team: Dr. Economou Mary, the clinical dietitian, Dr. Kouta Christiana and Dr. Midleton Nikos, associated professors, Stelianou Konstantina, the integrative oncologist, Dr. Orfanos, the medical oncologist, Dr. Ferendinos, the director of radiation oncology department of German Oncology Center, and Haralambos Andreas as the supervisor. Symposium is funded by Baxter, and participation at EONS14 at ESMO 2021 is supported by German Oncology Center and Cyprus University of Technology. Let's start with the introduction. Cancer-related cachexia definition is a multifunctional syndrome characterized by an ongoing loss of skeletal muscle mass that cannot be fully reversed by conventional nutritional support, and progressive functional impairment. The pathophysiology is still complicated, but let's say that it's a negative protein and energy balance driven by a variable combination of reduced food intake. The reduced food intake maybe is because of the side effects of the chemo or because of the tumor itself. Cancer-related cachexia can affect about 80% of advanced cancer patients and can cause 20 to 60% of cancer deaths. Our randomized controlled trial aims to evaluate the effectiveness of a multimodal education and support program for the prevention of cancer-related cachexia for patients and their family caregivers during anti-cancer treatment. We always choose the patients from time 0, so they have their consultation with the oncologist, and then he refers the patients to the randomized controlled trial. The participants must be about 60 cancer patients, and for the moment we have 63 active patients in our randomized controlled trial, in two comparable groups, control and intervention. In the intervention group, we have the multimodal education and support program with the oncologist, the cancer nurse, the clinical dietitian, and the integrative oncologist, and the telephone support by the cancer nurse. In the control group, we have only the usual care plus 10 steps for better nutrition through the treatment, and also the telephone support with the cancer nurse. Here, we have to mention that the patients always, if they have any severe side effect, they are moving to the intervention. The eligibility criteria for our randomized controlled trial are inclusion criteria, the solid tumor diagnosis, participants must be under 18, read and understand Greek or English, participants needing chemotherapy, immunotherapy, hormone therapy, or intravenous anti-cancer treatment, participants in normal or pre-cachexia stage. In the exclusion criteria, we have dermatologic tumors because of their specific diet, parenteral nutrition, ECOG performance status more than 2, participants who cannot introduce a caregiver, and participants in cachexia or refractory cachexia stage. When we have solid tumors, we are thinking only about 5 types with high percentage of cancer-related cachexia, like lung, pancreas, colorectal, stomach, and breast. When we can find the patient with cachexia or refractory cachexia stage, we immediately put the patient in the intervention, but the measurements are not included in the study. Today, I'm going to show you with my team only 4 lung cancer patients, 1 advanced and 1 localized cancer patient in each group. So in the control group, you will see the results or some of the results for the patient with stage 1 and for 1 patient with stage 4. For the intervention, you will see the results for 1 patient with stage 3 and 1 patient with stage 1. You can see the different color in the last shape, the yellow one, because she's a woman. The other are men. All of our patients that we focus today are smokers or they were in the past. In the intervention group, we always have 4 appointments, 4 weeks in between, total 12 weeks of the education. In these 4 appointments, let's say once a month, we have the education and support with the team. As I said, with the oncologist, the cancer nurse, the clinical dietitian, and the integrative oncologist. Always in the intervention, the patient has the body composition with the medical scale for the muscle mass, the fat mass, the weight, the edema, the sarcopenia, and lots of other things. The blood test for the C-reactive protein and albumin levels. The clinical assessment for the oral and oral health like stomatitis, mucositis, skin side effects like dermatitis, and other things from the chemo. The nutrition counseling and the symptom management education. Always in the intervention, we are giving a small booklet that we prepared with some recommendations that we already discussed with the patient in each group. In the control, we have also 4 appointments with the body composition, like before, with the blood test, and with the clinical assessment, like the oral, the skin, and so on. But at the end, we always add 2 more appointments with education and support with the team. It's important for the ethical reasons to give the patients the intervention at least at the end. If there is any chance to find the patient with cachexia or refractory cachexia stage, we always move the patient to the intervention and exclude them from the study. As you can see on the image, if you believe it, it will affect you. So to see the results from the intervention, we always ask for the compliance of the patients, because we always recommend things, but who knows what they follow in the daily routine. So we always ask for the 24-hour dietary recall to check if they used to follow our recommendations, or they're, let's say, skip their meals or add more sugar than the normal, or use foods that they have to avoid. Here you can see the results from the first patient of the intervention, which is a patient with stage 3. He is a man with diabetes. So this patient, as I told you, is a smoker, and as you can see, the weight with the blue one, which is the baseline, and with the orange one, which is the post-intervention weight, it increased. You can also see the increase of the muscle mass and the decrease of the fat mass after the intervention. In the patient number 2, who is a woman, as I told you before with the yellow shape, it was a woman smoker too at the moment. She was without any chronic disease, and as you can see here, her weight it was a little bit more, the muscle mass are more, and the fat mass are stable. Even if it's stable, for us is really important. Here you can see the first patient from the control group, who was a man. It was a smoker with no chronic disease, and actually, as you can see, he was overweight. The weight it was decreased, the muscle mass too, and the fat mass it was a little bit more. In the control group, the patient number 2, it was a patient with stage 4. Here, it was a past smoker with diabetes, hypertension, and let's see that the weight it was more, the muscle mass was less, and the fat mass it was increased. So this patient, it was with high toxicity, with lots of side effects, but not a severe level to move him to the intervention. It was because of the corticosteroids, because he was also with metastasis on the brain, so he had to follow the corticosteroids in daily routine. Let's summarize the results. We don't have yet the statistical results to show you percentage and so on, or p-value results and so on, but we can summarize that the weight in the intervention was stable or increased after the intervention. The muscle mass was stable or increased too, and the fat mass was stable or decreased in some cases. In the control group, the weight was decreased or increased because of corticosteroids in some cases after the placebo intervention. The muscle mass was decreased after the placebo intervention. The fat mass was stable or increased after the placebo intervention. The protein intake used to increase in the intervention group after 12 weeks of intervention, and the edema was stable or slightly less. In the control group, the protein intake was stable or less, and the edema was getting more and more. Here is really important to let you know that on the control group, when we had 2 more appointments with the patients, they used to have better results after the intervention. We had the patients that after the recommendations, it was full of power, less toxicity, lower fat mass, sometimes lower weight, and stable or increase of the muscle mass. Take-home messages. So, the first thing is to assess your patients for cancer-related cachexia. Let them know what this is and what they have to do or what they have to avoid and why it's really important to focus on their diet or their daily routine, like activity, hydration, and so on. Enroll the family caregivers in the treatment plan and refer them to the other specialists like clinical dietitian, integrative oncologist, clinical physiologist, and so on. For us, it was really important to see the patient's stress level getting lower with the intervention because they had the support. They felt that they were included in their treatment. It's important to have the family caregiver too, because they always push the patient to avoid some food or to eat more, even if it's something full of sugar or full of processed. So include them in the treatment and ask them about questions. Recommend them things that they don't really imagine that it could be helpful. Ask the patient, because sometimes, even if you don't think about it, they used to have pills for animals because they think that it is a magic solution, or they used to eat trees, to follow recommendations by anyone because they are trying to find the magic solution, but there is no magic solution. The things that they have to follow is the hydration, so more water, more active, to have the stable or increased of the muscle mass. And the third one is the high protein intake, and try to manage their symptoms at home. They have to know how to do it by themselves. It's important to feel safe, to reduce the toxicity, to increase the quality of life, and to help to have better relationships in between the family. Thank you.
Hi. Hello, everyone.
Hello. Thank you for your excellent presentations. We have some very interesting questions. I might start with Julio. Julio, you talked during your presentation about the parental nutrition. Can you say something about the risks with parenteral versus tube feeding?
Julia?
You are muted, Julia, sorry. Okay, no, we cannot hear you. I believe I will ask the technical team to help Julio, and I will move on then to a question to Joanna. Thank you for your presentation. It was very, very interesting. You talk also about education on these fields of nutrition for cancer patients. Do you have, someone is asking if you have results in publication process, or did someone miss that information? So this is for publication or not?
Yes, the study has been submitted and approved, and it will be published sometime soon.
Great. And would you recommend to do this type of studies in other European countries, or do you aim to do that?
Well, definitely, cross-country exploration of this issue is very important and will give us a wider aspect of the knowledge of the cancer nurses in the syndrome. No, we haven't studied something like that for now. But based on the current studies, there are similar findings from the other countries. For example, they don't use some guidelines because until recently they didn't exist. So now it remains for them to be widely disseminated in clinical practice. And then, yes, it will be very interesting to do a larger study in many European settings.
Yes, I believe this also reinforces the need for nurses to have a common core curriculum, which includes this type of content. You say that during your presentation that the educational programs are different in Cyprus and in Greece, and that might impact the results. EONS recommends this topic in our education framework, and we are also now developing the Nutritional Nurse education project, but it would be very important for all nurses at the European level to have education on this. So, and Constantina, how would you describe cancer nurses' role in the multidisciplinary team? What are their main tasks?
So Sarah, actually, through other studies, all of these years, we are the most trusted healthcare provider for the patient. So they used to ask more things nurses than the doctor, because they don't want to bother them, or they are shy to ask for more. So they will have to discuss everything on their side effects with the cancer nurse. And I think, or in my opinion, is a key role in the multidisciplinary team to discuss with the patient, to assess their symptoms, and to educate them how to manage their malnutrition or their side effects to keep their diet as normal. This is my opinion.
Thank you. And Joanna, would you think it would be useful to have a tool or to develop some kind of instrument to investigate the nutritional status and evaluate patients with cancer cachexia?
In order for a cancer nurse or a cancer ward to begin to assess, to routinely assess cancer patients for cachexia, a simple tool could do for the beginning, like the PGSGA. And then after identifying the issue in their specific group of patients, they could proceed to validate and create and validate a questionnaire which will be specific to their patients, and they could adapt and cultural aspects of the nutritional care in the tool. So yes, validated tool is definitely better than a simple tool for the patients, and it is worth doing it separate in many settings.
Okay, and from your experience, Joanna and Constantina, do you feel that the nutritional status of patients is routinely assessed? Constantina,
Based on my, let's say, on my practice and on my experience during these 4 years on cancer-related cachexia, nurses, maybe they are assessing their patients on malnutrition, but not official. Actually, maybe it's a question during their discussion or something else. And when the patient, let's say, is asking something about their diet, because they're always worrying about what to avoid or what to eat during the treatment, maybe they will assess or give some recommendations on their patients. But routinely, we are not assessing the cancer-related cachexia, because through the study that Joanna shows you, nurses even they don't even know the definition of cancer-related cachexia, so how they could manage it. And please remember that the ICMT code that it was in October for cancer-related cachexia in 2020, so it's very, let's say it's a newborn, it's something very new for the patient, for the healthcare providers. So they have to do it. As Joanna said, it must be in their priorities.
Yes. Would you like to add something, Joanna?
Totally agree with Constantina. We at the nursing charts, we state the weight loss, the anorexia, and the other symptoms that are related to the syndrome, but we do not know that we are doing it officially and typically. Moreover, we do not do it in a specific time frame, like each month or each 2 months, or in every session of chemotherapy or radiotherapy. We mostly do it randomly when the patient discusses it with us. So a tool will help with that, and education, of course.
Thank you. And now I think we have Julio. We can hear you. Hello, Julio.
Hello, how are you?
Hello, thank you. Your presentation was very interesting, and we have several questions for you as well. So you highlighted the need to detect malnutrition or the risk of malnutrition at an early stage. What instruments would you recommend to use in risk assessment and also in follow-up?
Okay, there are some points to be clear from the beginning when patient comes to the consultation. When patient come to the consultation in the early stage, we usually don't ask them a lot about the nutrition, or we don't see the flags about the risk of malnutrition. But I think we can put in order the assessment of the malnutrition or the malnutrition risk, asking them about, there are some validated instruments we use in our study, Nutri-Score, and asking the patient about the subjective feel about the nutrition. And we need to perform a body decomposition. Maybe in our study, in next study, we need to ask for a body decomposition, because this is interesting, the balance of the fat, the protein, the bone, and sometimes we need to dig into in our assessment. And maybe I wrote in the answer, maybe we need to enter in the kitchen of the patients. We need to ask the patients, we need to ask the family, and this is very important, because it's not only about a test, an assessment, and say, okay, you are in risk or you are not in risk. You need to perform a whole assessment and a follow-up in every stage of the illness, because sometimes one patient are okay, and the next month he's not okay or she's not okay, and we need to ask every single time the patient, how about your nutrition, how about your feeding, you are okay, and we need to flag the alerts. We need to control the weight and the body composition. I think this is important. We use in our coming back to your question, we use the Nutri-Score. We think is a good assessment, because it's short and easy to perform, and I think it gives a lot of information. I don't know, maybe we need to adapt to every culture, to every stage, and sometimes we don't take into account we have patients from rural areas or from the city, and there are very, very different differences into this. Almost in Spain, or I don't know, maybe there are very differences between countries. And oh yeah.
Apologies, I totally agree with you, Julio. We need to do a comprehensive evaluation and approach, not only for the body composition and the way of the patient, but also for their emotional distress, their anxiety, their family support, because that's something that really impacts their nutritional status and their will to eat. It's something that really impacts our patients as well. And I have another question for you. You mentioned during your presentation that all available nutritional support options should be considered, from dietary counseling to total or supplemental parental nutrition. However, in the study, it's noted that dietary advice was the most common type of intervention. Could you comment on these results a bit further? Do you think that this type of intervention is enough, or do you have any recommendations for?
I think the audience told, okay, Julio says about dietary counseling, about health education. Sometimes in the consultation, we don't have time with the patient, but we need to back off our time and write or in the history of the patient, the clinical history, and say, okay, with our data, we need to perform a specific and personalized plan for our patients. And maybe normally patients, this morning in Twitter, I saw an image of a large file of people asking for pills and surgeries, and there is no place to change habits or change the way of life. With oncology patients, it is the same. Usually the patients don't want to change cholesterol, they don't think about that. And it's a good moment too for the patients to change if they don't have a good habit. And we need to have a wise vision of the needs of the patients. And sometimes patient needs complement supplements, and not in a big country, great doses, but they need to be firm and they need to be supported by us with a good counseling, and when it is necessary, supplements or anything they need.
Thank you. And I have a question for the three of you. What is one key message you want to give to the audience that you think it would improve how we manage cancer-related cachexia? Constantina, can I start with you? Please turn on your microphone. Sorry.
I'm gonna take few things from Julio, and I'm gonna mention once more that through his presentation, more than about 60% of chemo patients has malnutrition, so we have to focus on them. And as you said, Julio, it's important to assess but manage also the cachexia, because if we find it and we cannot do it anything, there is no reason. For me, it's important to mention to healthcare providers that cancer-related cachexia is important for the prognostic score, for the quality of life of our patients and their family caregivers, and for the outcome for the treatment. Because we always know that from the beginning, we measure our patients for the dose for the chemo, but maybe we have to increase or decrease because of their cancer-related cachexia during the treatment plan. It's also important to focus, as Julia said, on the family caregivers, because usually the patient is on fatigue or some side effects and they cannot even cook. So they have to be in the team and teach them how to cook or how often the patient must eat. It's really difficult to say that sometimes we found patients that used to drink tablets for animals because they thought that it was a solution for their cancer. So we have to teach them what to avoid or what to follow to their dietary intake. That's all from me.
Thank you, Constantina. Joanna, one key message for the improvement of how we manage cancer-related cachexia.
This is a very important issue, and cancer nurses must have their eyes and ears widely open to listen to the patient and properly assess them. Despite having a tool, education is very important to place the cancer nurses in the ideal position to manage the cancer-related cachexia. And cancer nurses must finally be confident and act to improve the quality of life of their patients.
Thank you, Joanna. And Julio, can you please conclude with your message?
In line with Constantina she says that it's not only about assessing, it's too about managing the nutritional status of our patient. We need to ask first and acting later. And the very first step is assessing, obviously, but we take part. We are in the first line of the control of our patients in the quality of life and the quality of feeding and nutritional. And we need to take part and be the special colleagues of our patients to manage the nutritional status with them like a team.
Yes. Thank you, Julio. I totally agree with you. It is important to assess and to manage it, to have education to do that, and do that in a routinely way, not only when the patient comes for the first time for the treatment, but do this periodically. So I would like to thank all of the speakers for their excellent presentations. To all the audience who sent very interesting questions, and for all the ones who are listening to us. And I would like to underline that we cancer nurses really have a pivotal role in the prevention and recognition of malnutrition, as well as in the management of situations that might require nutritional support. So hope that you stay around for all the interesting sessions in this EONS14 conference, and I hope to see you live next year.
We hope to.
Thank you all.
Thank you very much.